Risk stratification is another topic that is part of that population health management. This has long been used by health plans to establish premiums for members and to negotiate contracts with providers. In value-based care, providers are starting to use risk stratification to identify each patient's level of being at risk for significant health issues. In general, a healthy young person would have a low risk level. As people age, their level of risk naturally rises, but their lifestyle, chronic conditions, and predispositions, such as hereditary factors, can increase their risk over others of the same age with a different set of clinical and health-related factors. Those with emergent or sometimes called rising risk, which may be as many as 20% of the population, are often more aggressively targeted with health services because changes in their lifestyle and improved management of their current conditions can reduce the likelihood of needing much more intensive services later. In value-based care, patient risk stratification then is the intentional, planned, and proactive process carried out at the practice level to effectively target services to patients. Some other terms we should be aware of, though, may be either associated terms or synonymous terms, and these include risk adjustment. This is the term primarily used by health plans to identify risk factors and predict health decline as a function of actuarial science to determine premiums and fee-for-service reimbursement, and now in the context of value-based care, where it is intended to mitigate risk differences in reimbursement. These risk adjustment methodologies are generally proprietary and have rarely been shared with providers. Risk score. This is a term that generally indicates the likelihood of a single event, such as a hospital readmission within the next 6 months or a person's risk for incurring cardiovascular disease, for example, using the Framingham Heart Study. In comparison, risk stratification often combines several risk scores including age, gender, number of chronic condition, and other factors to create a broader profile of a patient and the patient's ongoing needs. So these terms, risk score and risk stratification, are really not synonymous. Risk adjustment could be synonymous with risk stratification, but because they are performed by two separate entities for really different purposes, I like to see them considered to be two different terms. Predictive modeling or predictive analytics is a branch of clinical and business intelligence that is used to forecast the future health status of individuals and to classify patients by their current health risk, which is risk stratification. As a result, predictive modeling is generally considered somewhat broader in scope and more forward-thinking than risk stratification alone. Predictive modeling is also used in risk adjustment by the health plans to compare the aggregate health risks of one physician's or one organization's patients to those of another physician or entity for purposes of contracting. This distinction is not to suggest that providers would not conduct predictive modeling, but only to distinguish the scope of the two processes. In fact, many providers are starting to conduct predictive modeling or analytics in order to shift focus from only short-term needs of patients to long-term population health management and including social determinants of health, which we'll talk about next. Predictive modeling or analytics helps make risk stratification actionable by providing information that can guide clinical choices and determine the probability of success with enough lead time to change the course of care. Predictive modeling or analytics should incorporate a clinical approach that may have been lacking in the purely actuarial models of risk adjustment. Now let's take a look at some of the risk stratification models. As I said, patient risk stratification is not new, even for providers, but has not been formally applied until recently within value-based care. As a result, a variety of different methods have been created and tested over time. Those listed here are the most commonly used today, although the list is not exhaustive by any means. Let's take a look at some of these. The hierarchical condition categories, or HCC, is used by CMS, so it is perhaps the most widely used. It contains 70 condition categories selected from ICD codes and includes expected health expenditures. I would note, however, that 2 different versions of HCC is used within CMS. So even though there's an opportunity for standardization here, not so. Another model of risk stratification is the adjusted clinical groups created by the Johns Hopkins University, which contains 93 categories of inpatient and outpatient diagnosis to predict hospital utilization. So this is a fairly focused model on just the hospital utilization. The Elders Risk Assessment uses age, gender, marital status, number of hospital days over 2 years, and comorbidities to assign an index score. Now this is really only for the elderly, but that is an increasingly large number of people in the United States and has proven quite useful in looking at how we might stratify our more elderly population. The chronic comorbidity count is from the Agency for Healthcare Research and Quality Clinical Classification Software. 6 categories using selected comorbid conditions are used to highlight annual and persistent costs. So this is focusing on disease rather than other social determinants. Minnesota tiering is a product of actually the adjusted clinical groups from Johns Hopkins, major extended diagnostic groups. It is used by the state of Minnesota to determine management fees for care coordination among medical home plans, patient-centered medical homes, based on 5 patient complexity levels. The Charlson Comorbidity Measure classifies comorbidities affecting 1-year mortality based on 17 comorbidity conditions and administrative data. So this is looking at what is the most likely to cause death. And finally, the 8 Ps from Project Boost, which has an implementation toolkit, is a simple set of risk factors, which are problems with medications, psychological, principal diagnoses, physical limitations, poor health literacy, poor social support, prior hospitalization, and palliative care, all starting with P, for hospitalized patients. So again, this is really focused just on hospital patients, but the areas that they are most concerned about in terms of ensuring readmission does not have to occur. All risk stratification models that we've discussed here are based in some degree on comorbidity, a factor that has been found to increase costs by as much as 7 times as those with only one chronic condition. As can be seen in the models listed here that are generally being used by providers, several of the methods are similar while others are fairly unique to a specific population, such as the elderly or hospitalized. What is not available from a review of the literature, though, is the extent to which these publicly available models are used in proprietary formats by commercial health plans, which has the potential for skewing results when risk stratification is used in comparisons of patient populations by health plans for setting premiums and negotiating provider contracts. CMS does publish its two forms of HCC usage. Providers would certainly benefit from knowing how risk stratification is being modeled for their contracts by commercial plans so that they can get on the same page as their plans, benefiting both themselves by reducing their risk and the plans by having to pay out more in claims if providers are successful in mitigating patients' risk. In summary, then, we can identify some challenges in using risk stratification as lack of transparency, certainly as we've discussed here, as well as issues with data accuracy, availability, and accessibility, and then actually using the results of the stratification to develop and carry out an action plan for patients. Because some of the factors used in risk assessment require data that heretofore providers have not routinely collected, they may not have access to such data or may not think about keeping such data up to date. For example, it has been found that patients who are living with their spouses have slightly lower health risk than those who may never have married, are divorced, or widowed. This information may have been collected on a patient questionnaire when the patient first became a patient of a given provider, but the data are often not entered in structured format into an EHR or perhaps only scanned into the EHR, and it's rarely kept current. Accuracy of coding is also very important. Physicians are just starting to use ICD-10-CM for diagnosis coding and may not take the time or otherwise be inclined to use the most granular codes possible. It is also very important for all data to be coded and to ensure that all codes are submitted and used by the health plan. We've noted before that many claims processors have limited the number of diagnostic codes, such as 4 for physician offices. The HCC model used by CMS becomes much more accurate with a full complement of codes for each patient. It is also important to code comorbid conditions on every patient visit. Finally, developing and maintaining a plan of care for the patient is also not often performed by physicians, as this was not reimbursed for under a fee-for-service payment model. And if such is developed, it typically is done for a specific disease condition and is not a holistic plan that includes wellness and prevention. In value-based care, taking the time to do this will reduce risk. But during a transition period where physicians are not seeing direct results and still must attend to patients in a fee-for-service environment as well as those in value-based payment program, can be a challenge to adopt. So we've talked a bit, several times actually, about social determinants of health. So let's take a look at the need to address the social determinants of health as part of health care versus medical care and with respect to population health management. Such need is really critical. The World Health Organization, or WHO, defines social determinants of health as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life, which are economic policies, development agendas, cultural and social norms, social policies, and political systems. Physicians know at least many of these all too well, such as when they identify that a child with asthma whose substandard housing is triggered repeated emergency department visits, or the patient with repeated visits for severe abdominal pain is caused by her violent home life or anxiety over financial situation. And another example, the older adult with diabetes forced to choose between paying for heat and buying groceries. These are just a few of many examples that we know physicians are definitely aware of. But because current value-based care payment programs do not account for social risk factors for poor health outcomes, these programs may underestimate the quality of care provided by providers disproportionately serving socially at-risk populations. As a result, these providers may be more likely to fare poorly on quality rankings. And when payment is tied to these rankings, these providers may also be more likely to receive penalties and less likely to receive incentive programs, and hence less likely to voluntarily participate in value-based care. It is essential to the success of value-based care, then, to address social determinants of health. But first, we must identify what these are, how to collect such data in a usable manner, and, much as with risk stratification, learn to apply the factors. But this time, the application is not just getting physicians to incorporate into and implement a plan for each individual patient, but to address the community services needed to make improvements that certainly go beyond the scope of most provider services, although some health plans have started to address some of these issues directly. So what is being done to address the issues? The National Academy of Medicine, as part of its Vital Directions for Health and Healthcare initiative, has conducted 5 coordinated studies to raise awareness and propose recommendations. And if we recall, the National Academy of Medicine is essentially the think tank for Congress. These initiatives have contributed not only to improvements in provider and EHR vendor awareness, but also ONC incorporating social determinants in its 2017 Interoperability Standards Advisory. The major categories for which I've listed here on this slide, and they are representation of financial resource strain, level of education, stress, depression, physical activity, alcohol use, social connection and isolation, and exposure to violence, including intimate partner violence. CMS is directing funding under its Center for Medicare and Medicaid Innovation, CMMI, for testing social determinants of health models, and other state, local, and private payer philanthropic initiatives are occurring. For example, there is a 5-year funded program with a variety of initiatives, including the Accountable Health Communities model, identifying 44 organizations to serve as bridge organizations supporting clinical and community services. This is being done by the CMMI. Hennepin Health, a county-based Medicaid managed care organization in Minnesota, is using housing and community service specialists to integrate with medical and social services, already seeing reductions in emergency department visits by 9%. The Chicago-based Community RX generates prescriptions for community services through an interface linking the patient's EHR with a community resource database. And finally, several major payers are creating foundations to invest in community interventions, employment, environmental stability, and others. It is clear that this is very early work. There remain many variations in what are considered the most important social determinants of health, how to collect them, and what to do with them at each level at which they must be addressed. Just because ONC has incorporated some of them into its interoperability standards advisory does not mean they are mandated for inclusion in health IT. CMS funding is always tenuous, and regulation that would be needed to improve adoption of standards is not always feasible, at least for a fairly significant period of time in which thorough testing and financial burden on all stakeholders is determined. However, there are initiatives that we have seen that are paying off, as evidenced by the two examples from Hennepin County and Chicago, and the work that's being done by both public and private payers. So in summary, population health management is certainly one of the newest additions to the arsenal we have to assure success with value-based care, and certainly many opportunities for new forms of employment. Because population health incorporates many diverse concepts, much of which are new to all of us, the references for this lecture are perhaps a bit more extensive than for other lectures, and so I've broken them down by the four main topics covered in this lecture. I look forward to continuing the discussion of population health in the last lecture in Unit 8, which concludes this MOOC. So references on population health management, references on provider attribution, provider patient and device identifications, references on risk stratification, and references on social determinants of